mind-boggling. Our next session is about cerebral physiology and its anesthetic implications. I call upon the chairpersons for the next session, Dr. Ratna Rao, present HOD Anesthesiology and OT Coordinator at Rangadore Memorial Hospital, former HOD Anesthesiology Pain and Critical Care Ramaya Medical College, former Director Critical Care Services MS Ramaya Group of Hospitals, and a recipient of a ISA Lifetime Achievement Award. We welcome you, ma'am. Our next chairperson is Dr. Archana KN, Professor and HOD, Department of Anesthesiology, JSS Medical College, and a BLS ACLS instructor. I request the chairpersons to introduce the speakers.
Which is basically, we confine ourselves to the neuroanesthesia section. And we have very experienced, worked in those areas for many, many years from prominent hospitals and centers. And to begin with our neuroanesthesia, the basic physiology is very important regarding cerebral blood flow, cerebral physiology, which forms a platform or a fundamental before we move on to clinical aspects. So our speaker, the first speaker will be Dr. Baburaj, Professor and Head of the Department of Anesthesiology, Thrissur Government Medical College. And he will be speaking to us about cerebral physiology for anesthesiologists. I welcome Dr. Baburaj.
Respected chairpersons, respected teachers, and dear friends. See, probably the most important organ in the human body is brain, the most vital one. And this is an organ having highest metabolic activity with no energy reserve. And every anesthetic procedure and most of the anesthetic drugs have an impact on the cerebral physiology. So, every anesthesiologist should have these four goals in mind: to maintain blood supply, to maintain the glucose supply, to maintain oxygen, as well as to maintain intracranial pressure. Let us start with the Monro-Kelly doctrine. So, this was introduced, this is also called the Monro-Kelly hypothesis. This was introduced by Alexander Monro and George Kelly, both were Scottish surgeons. This doctrine says, since the cranium is a closed cavity, the total volume is to be kept constant. Any increase in any of the components has to be compensated by reduction in other. See, this cranium, which is closed cavity, having the highest percentage of brain parenchyma, about 80 to 85%. Then blood volume, which includes both arterial and venous, which is about 10%. And then comes CSF, which includes some interstitial fluid also. So, if any increase in brain tissue happens, it should be compensated either by reduction in the blood or CSF or both. Suppose there is an increase in the brain parenchymal volume, two things should happen. So, there should be a reduction in the cerebral blood volume, or there should be a reduction in the CSF volume, or both. Now, this is a very simple, symbolic representation of the cranial cavity. We can see all the components: brain, CSF, the blood, which is again arterial and venous. Here the volume is not increased for any of the components and ICP is normal. The next picture you can see that there is a tumor. There is an increase in the volume of parenchyma, which could be a hematoma, which could be a tumor. Now what happens is the blood volume is reduced, mainly the venous blood is affected, and CSF is also reduced or displaced from the cranium. Now this is known as the volume buffering. Now decrease in cerebral venous blood volume is something which happens immediately. And then comes the decrease in CSF volume, which happens in 3 steps. Number 1, spatial compensation. What does it mean? The CSF is moving from the cranial cavity to the spinal cord, spinal canal. the CSF absorption is increased, and CSF production is decreased. These are the main mechanisms happening in the CSF. Now, this picture shows there is a tremendous increase in the volume of the cerebral parenchyma. The compensation has reached its limits. Now, what happens? There is no way other than increasing the intracranial pressure. Now, what are our concerns about raised ICP? Number one, it reduces the cerebral perfusion pressure and leads on to cerebral ischemia. And on the other hand, it also causes the herniation of the brain. Two things which worries us are ischemia and herniation. Now, let us move on to the next part, that is intracranial pressure. Normally, it is about 7 to 12 in the supine position. And it is a very dynamic one. When you are standing erect, it is low. When you are in supine, it increases. When you do some Shirshasana, it will further increase. So, it is a very dynamic one. Posture affects it. Arterial blood pressure affects it. Cerebral venous volume, that means suppose there is a kinking of the veins or anything which can increase intrathoracic pressure. So, all this can affect the venous pressures and can increase ICP. And respiratory cycle, somebody on controlled ventilation, ICP increases during inspiratory phase, and if you have a PEEP applied, then also it can increase the intracranial pressure. And cough, bucking, coughing with tube in situ, do extubation and patient is bucking. So that is enough to cause an increase in the ICP. Now coming to intra, I think every postgraduate should have this picture in mind whenever you anesthetize somebody. You can see there is an increase in the volume of the brain parenchyma in the form of a hematoma or a tumor. You can see that the volume is increasing, but ICP is maintained to up to a particular limit. What happens thereafter? There is a sudden increase in the pressure. That means even a slightest increase in the volume is cause a tremendous increase in the ICP. The next picture shows you better. You can see there is compensation. Good. Now the compensation is coming down, and then what happens is there is increased risk of raised ICP. So if you think about your neurosurgical patients, most of them are near that curve. You can call this as a knee of the compliance curve. Most of them are in the knee, and a slightest increase of volume will cause a tremendous increase in ICP and going to cause brain damage. Now coming to CF circulation, a usual question for all the residents during your clinical, practical viva. It is produced in the fourth ventricle from the choroid plexus, 500 ml per day. It reaches the third ventricle. There are choroid plexus there also. So it adds on to the volume. And now it reaches the fourth ventricle. Choroid plexus from the fourth ventricle adds more volume. And finally CSF goes to the spinal canal. And you can see the cerebral venous sinuses up there. And you can see the arachnoid villi. They will absorb the CSF. Now coming to cerebral blood flow. See, 70% of CBF is by internal carotid artery and 30% by vertebral arteries. And there is an anastomosis which is called circle of Willis, which was first described in 1664. Remember, 50% may have an incomplete anastomosis. And regarding venous drainage, it is from the cerebral venous sinuses, it goes down through the internal jugular veins. Now, the weight of the brain is about 2% only, but it gets about 15% of the cardiac output. You can say it is about 750 ml per minute, and during the resting phase, it is 50 ml per 100 gram per minute. And when you compare the gray matter with white matter, almost 4 to 5 times cerebral blood flow goes to the gray matter because it is metabolically more active. Now coming to cerebral perfusion, what is it? CPP. It is the difference between MAP and ICP or CP, which is higher. Or you can say it is a driving pressure which drives the blood through the brain. Normally it is about 70 to 80. And if it is going below 60 to 30, it is called critical ischemia. And suppose there is a normal MAP, but your ICP is increasing, that is definitely going to reduce cerebral perfusion pressure. Now, coming to cerebral blood flow, so many factors are affecting. This picture tells you the different factors which can affect CBF, starting from cardiac output, cerebral autoregulation, carbon dioxide, oxygen, and nitric oxide, and metabolites like glucose, lactate, sympathetic and parasympathetic activity, and last but not is the neurovascular coupling. These are various factors affect. We'll just go through each of the components. Cerebral autoregulation. What is it? It is the ability to maintain a constant cerebral blood flow in spite of changes in cerebral perfusion pressure. Usually the range is 50 to 150. Now, what's the difference between MAP and CPP? MAP minus CVP or ICP is CPP. But practically it is difficult to measure ICP. So, you can consider MAP as a surrogate of CPP. Okay. So, this picture tells you everything about the cerebral autoregulation. You can see between 50 and 150, the blood flow is maintained. How? It is by change in the cerebrovascular resistance. You can see at the top, the vessel's diameter is changing. When the BP is low, you can see vessels are dilated. When BP is going high, vessels are constricting. It's a complex mechanism. There are different factors involved. And now the recent studies have shown that the autoregulation is more effective when BP is going up. In the lower BPs, it may not be as effective as we thought about. Now, what happens when the BP goes below this 50? You see, vessels are no longer able to dilate, and the result is nothing but ischemia. And what happens when the BP is going up? There is forceful dilatation, and that result in vasogenic edema. So, we need to maintain an MBP of 50 and 150, beyond which cerebral autoregulation doesn't work. Now, mechanisms are myogenic, neurogenic, metabolic, and endothelial. Myogenic means the contraction and relaxation of arteries and arterioles in response to decrease or increase in ICP. And neurogenic means it is because of various neurotransmitters. And metabolic, it's a reflex vasoconstriction. Suppose there is increase in blood flow. Carbon dioxide will be washed away. And when carbon dioxide is washed, what happens? There is vasodilatation. When the blood flow is less, vasoconstriction. And when the blood flow is decreased, there will be accumulation of carbon dioxide and there will be vasodilatation. And last is endothelial, in which nitric oxide, which is a vasodilator, and thromboxane, A2 and endothelin, they are vasoconstrictors. Now coming to PaCO2 and CBF. See, between 26 to 60, some books says even 80 millimeters of mercury, there is a linear relationship. See, for every 1 millimeter rise in PaCO2, CBF increases by about 1 to 2 ml per 100 gram per minute, and vice versa. And when you reduce carbon dioxide, the vasoconstriction happens, and it happens in seconds. Vice versa also. And remember, this can last only for 6 hours. Why? 6 to 8 hours, because then the compensation happens in the form of diffusion of bicarbonate. So even if you try to maintain vasoconstriction by hypocapnia, it will last only for 6 to 8 hours. And another thing is, earlier we thought of providing a low PaCO2 and reducing ICP, but the problem is cerebral ischemia. So always try to maintain PaCO2 within the normal limits. Too much reduction can cause cerebral ischemia. Now coming to PaO2, CBF will increase if there is a reduction of PaO2 about 50 to 60 millimeters mercury. Temperature. See, when there is a decrease in temperature, there is a drastic reduction of CMRO to 6 to 7%. That means by about 18 to 20 degree, the CMRO2 decreases beyond EG suppression. See, when you give thiopentone, EG can be made flat. But further reduction in metabolism can be attained by hypothermia, which is made use in post-cardiac arrest management as well hypothermic cardiac arrest. On the other hand, increase in temperature is going to increase CMRO2 up to 42 and thereafter CBF will decrease. You know something about cerebral metabolic rate? It is a rate at which brain utilizes the metabolic substrates, oxygen, glucose and lactate, right? You call it a CMRO2, CMR glucose, CMR lactate. And the brain has the highest requirement of metabolite, I said earlier. And energy production mainly depends upon the oxygen-dependent glucose metabolite, that is oxidative phosphorylation. Now, when you come to the CMRO2, the gray matter has a high metabolic utilization, 4 to 6 book says, and white matter it is about 1 to 3. And you know the oxygen consumption is 50 ml per minute. The total body it is 250 ml per minute. So very high oxygen concentration. See, out of this metabolic activity, 40% is used for maintaining cellular integrity, while 60% is for neuronal activity. Now coming to glucose, CMR glu. See, the whole brain glucose utilization is around 5 milligram per 100 gram. It is around 20% of total body glucose utilization. And it is the main substrate. And it is not only the substrate, it is also a precursor for many neurotransmitters like gamma-aminobutyric acid, glutamate, acetylcholine and so on. And when it undergoes oxidative phosphorylation, 36 molecules are generated, 36 ATP. Under anaerobic conditions, it is only 2 ATP, that is from the lactate. And remember, when somebody is fasting, ketone bodies can also act as substrates. So this is a simple picture. You can see this neural synapse here. You can see the capillaries there. You can see the astrocyte. See, oxygen from the capillaries can go directly to the neurons. And there, you know, majority of the oxidative phosphorylation happens and 36 ATPs are produced. And this astrocyte, which is a supporting cell, which can provide lactate. Of course, their energy production is only 2 ATPs. Now, something about flow metabolism coupling. It is also known as neurovascular coupling. See, whenever there is neuronal activity, metabolic rate increases, cerebral flow increases. When you read, when you try to remember something, when you move the thumb, the corresponding area will have increased metabolism, increased cerebral flow. This is called flow metabolic coupling or neurovascular coupling. Okay, it happens within seconds. Now, nitric oxide is considered the main chemical mediator for this neurovascular coupling, even though so many other neurotransmitters are implied. And what happens? You can see this picture. Whenever there is an increase in the CMRO2, CBF increases. Reverse also. When CMRO2 reduces, metabolic activity reduces, then CBF comes down. And what about anesthetics? I think next speaker will be telling more about brain blood and all that. So, intravenous agents except ketamine, of course, you know, they reduce the cerebral metabolism. So, because of the coupling, the cerebral blood flow also come down. Of course, by increasing the cerebral vascular resistance. What about volatile agents? You know, all the volatile agents are going to put you into sleep. So, naturally, they should reduce cerebral metabolism and should reduce CBF. But there is a catch. All the volatile agents are direct vasodilators. So this can lead on to uncoupling. So when you, so at low MAC, most of the anesthetics like isoflurane, desflurane, sevoflurane, they reduce CBF, but high MAC, actually isoflurane and desflurane increases the cerebral blood flow, but interestingly, sevoflurane will maintain. Probably for the neuroanesthesiologist, sevoflurane will be the most preferred inhalation agent. You can see with most of the IV agents, there is a reduction in the CBF because of the reduction in the CMRO2. With inhalation agents, there is an decrease in the CMRO2, but because of the direct vasodilator effect, it can cause increase in CBF with a high MAC. To sum up, see, brain utilizes large amounts of energy for its integrity and functioning, derived from glucose and oxygen, which are supplied by the cerebral blood flow, which should be constant, which is regulated by different metabolisms, different mechanisms I mentioned: cardiac output, cerebral autoregulation, carbon dioxide, oxygen, and so on. So, ultimate duty of anesthesiologist is to preserve the cerebral blood flow, to control ICP, and to maintain perfusion, oxygenation, and glucose supply. Thank you. I thank the organizers for giving me the opportunity. Thank you all.